All right, I'll go ahead and get started. So my name is Gopi Shah Goda. My co-author Norma is not here, but she's at the University of Washington. And I just want to acknowledge funding from the U.S. Social Security Administration through the NBR Retirement Research Consortium. And this work is very preliminary, so this is a paper that we just worked on this summer, and we're really eager to hear both Jay's and the audience members' comments on the paper in terms of how we can improve it and where to push it forward. So I just want to motivate this exercise by discussing a little bit about the CBO report. It was actually an appendix that talked in detail about how the CBO estimates the effect of the Affordable Care Act and the impacts that it'll have on labor supply decisions. And relative to the original estimates of how the Affordable Care Act would impact labor supply, the report that came out earlier this year estimated a much larger response to some of the aspects of the Affordable Care Act in terms of how people would choose to supply labor going forward. And the number that they came up with is quite large. So this is a quote from the appendix that I referred to, and it says that the CBO estimates that the Affordable Care Act will reduce the total number of hours worked on net by about 1.5% to 2% during the period from 2017 to 2024. And this is almost entirely coming from labor supply responses rather than labor demand responses. So they anticipate basically that the entire labor force will be smaller as a result of people choosing not to participate in the labor force or supplying fewer hours as a result of the Affordable Care Act than they would have otherwise, rather than reduction in the labor demand from employers who would lead to a higher unemployment rate, although the short-term effects are slightly different from the long-term effects. So where are these responses coming from? The report that I mentioned basically discusses 4 different aspects of the Affordable Care Act that is projected to lead to these changes in labor supply, although they don't separately describe the quantitative contribution of each of these 4 factors in terms of that 1.5 to 2% number, because there's just a lot of uncertainty in terms of how each of these aspects will affect labor supply. So the first thing is just the subsidies for health insurance that are purchased through the exchanges. So the idea is if you earn between 133% to 400% of the federal poverty level, then you are eligible to receive subsidies that allow you to purchase insurance through the exchanges. And so that can lead to incentives to supply less labor in order to get under the thresholds. It imposes an additional tax on working more within that range of income, because as you earn more income, the subsidies are less generous, and so that imposes a tax essentially on working more. The second point is the expansion of Medicaid eligibility. So this is just the idea that if people can get their health insurance through Medicaid rather than through their employer, then they may have less incentive to participate in the labor force. And there's been some recent evidence on what happens when Medicaid eligibility changes that suggests that this effect can be quite large, that the presence of Medicaid can severely impact labor supply decisions for people in certain states where they had expansions or contractions of Medicaid programs. The third is the penalties that are imposed on employers that have at least 50 full-time equivalent workers that decline to offer insurance. And the CBO estimates that over the long term, that these penalties imposed on employers will filter through to reduced wages among people who are working at these firms, and so thereby impacting the labor supply decisions of those workers. And then there's also some new taxes that are used to finance the Affordable Care Act that are imposed primarily on higher income earners. That is basically the fourth thing on this list. And these are listed in the order that the CBO estimates that they will have an impact. One thing that they do look at, but it doesn't fall on this list, is basically this idea that the Affordable Care Act another aspect of the Affordable Care Act is that there will be a lot of changes in the rating regulations. So they will be imposing this guarantee issue and renewability clause on health insurance made available in the individual market, the small group market, and the exchanges. And along with these rating variations, which basically restrict insurers in terms of the prices that they can charge individuals who are purchasing insurance, basically means that you can't, you have to accept people who are coming to the exchanges to purchase insurance, and you can't fully reflect their increased risk in the premiums that you charge them, because you're prohibited from using certain health characteristics. You're limited to the ratio of the premiums for the oldest individuals relative to the youngest individuals can't be greater than 3 to 1. And there are a few other restrictions of that nature. So this is actually similar to some of the rating regulations that have been passed in different states. And so the goal of this paper is to understand how the state variation in rating restrictions has affected the timing of retirement behavior. So the idea here is basically that prior to Medicare eligibility, retirees generally have health insurance from 4 different sources. So one could be retiree health insurance from their previous employer. The second could be health insurance through their spouse's employer if they're continuing to work, or retiree health insurance from their spouse's employer if they offer it to spouses. The third is COBRA coverage. So this is coverage that you can obtain from your employer for a period up to 18 months following leaving a firm. And then the fourth is basically the individual market. And the idea is if you basically change the premiums that are available in the individual market, and so you essentially you change the prices of one of these 4 options, that it might lead to differences in retirement behavior, because people may be opting towards purchasing their insurance through the individual market or through the exchanges rather than getting it from one of these other sources. And there's some literature that has shown that these regulations seem to have the effect that they would reduce premiums most for older and sicker individuals on the individual market. And this makes sense because insurers are basically prohibited from using age and health status in developing their premiums. Okay, so essentially we're going to exploit the variation in state regulatory environments over time to estimate the impact of these regulations on retirement hazards. We're going to code a state as having a strictly regulated market if it has both a guaranteed issue and community rating regulation in place. So there are some states that only have one or the other, but we think that these have most bite if they're sort of done in conjunction. And the data on these state regulations was obtained from a few different sources and merged together with our data set, which is the Health and Retirement Study. There's been a lot of previous literature on the topic of health insurance and retirement behavior. I generally put this into 3 different buckets. So one is estimating the effect of COBRA coverage on retirement behavior. This was some of the early literature done in this topic. And the second is retiree health insurance, and there's a big literature on just the relationship between retiree health insurance and retirement decisions. A lot of it is reduced form. There's some structural models. The estimates vary a lot as to how much of an impact the retiree health insurance has on retirement behavior. Generally, the reduced form results range from, I think, about 30 to 80% in terms of the effect it has on the probability of being retired. The structural models tend to show smaller estimates on the order of 15 to 30%. And there's also been some more recent work looking at the public sector specifically, and also finds that retiree health insurance is important in retirement decisions in the public sector. There's also another strand of literature on rating regulations and premiums. This research has basically shown that these types of rating regulations do seem to have a large impact on the size of the non-group market and the price of policies that are available. Okay, so this just shows the number of states with strict health insurance regulations, and you can see that there's not a lot of variation over the study period that we're looking at in the HRS, unfortunately. But there is variation going in both directions. In some states, these types of regulations were implemented, and in some states, they were taken away. Okay, and that's basically the variation that we're going to be using in this paper. So as I mentioned, we're using the Health and Retirement Study from 1996 to 2010. We've linked this to the restricted geographic identifiers, and we're using a hazard framework, which is similar to the Behagle and Blau recent paper looking at the effect of changing the full retirement age on retirement behavior. So basically the HI variable here is going to be a measure of our strictly regulated market. And the outcomes we're looking at are exiting the labor force, a self-report of whether you're retired or partially retired, and whether you've claimed Social Security retirement benefits. As many of you in the room know, there's often multiple ways to define retirement, and so that's why we're going to look at three different outcomes. You might wonder why these could be different. And so exiting the labor force is basically a measure of whether you're currently working for pay, and retirement self-report is just are you retired or not. So it's possible that people could respond that they're retired from their career job, but they're actually still working at other types of jobs. So some of the differences will be explained by things like that. So the unit of observation, and this is similar to Behagle and Blau, is basically person months. So we construct observations for each month and then use the information about your experience in the labor force and your date of retirement to be able to infer which of those months you're in the labor force and not in the labor force. And you're going to be in the sample if you were working at 59 and 11 months. So basically, were you working prior to your 60th birthday? And the ways that you sort of exit the sample are either through claiming, exiting, or retiring. So we're considering all three of those absorbing states where you leave once and you don't come back. You could have died, or you could have left the survey for other reasons, basically stop responding to the HRS. Or once you reach age 65 or 2010, the last year of data that we're using, you would also be censored sort of out of the sample. We stop the analysis at 65 because once people attain age 65, they're eligible for Medicare, and the availability of health insurance outside of their employer would probably have negligible impact. So we're going to look at two different groups in addition to our main sample. We're going to look at people who are self-reporting that they're in fair or poor health status. And this is about 17% of the sample. And the idea here is, since the regulation should decrease the premiums more for sicker individuals, then you should see more of a response among people who report to be in poorer health. The second one that we're going to look at is spousal health insurance. So here we expect the opposite to occur. So we expect that if you have insurance, potential for getting insurance through your spouse's employer, if your spouse is working and their employer offers health insurance, then you should respond less because you have other sources of coverage. Okay, so the main effect that we would expect from this first specification that I showed you is that we would expect that having these strict regulations would increase the retirement hazards between 60 and 65. So if we look at the data, the table that we show is basically showing this specification for each age between 60 and 64. The reason we're looking at each age separately is we noticed some different patterns when we were aggregating different groups of ages together, and it seemed that there are different responses at different ages, and it made sense to sort of separate them. But we don't always find the hypothesized direction, and in fact, we don't find strong evidence that these regulations are related to these retirement hazards. So there's basically one positive and significant coefficient here. That's for age 63 in the top panel, which is exiting the labor market as the outcome. This is pretty large relative to the underlying retirement hazard of 2.2%. So the interpretation is basically that the strictly regulated market for 63-year-olds increases the hazard of exiting the labor market by 2.2 percentage points. But you see that that's basically the only significant estimate on the table, aside from one that goes in the wrong direction at age 60. So from this, we don't see a lot of movement in terms of the retirement hazards relative to whether the person is in a strictly regulated market or not. We then cut the analysis to look at people who are in fair or poor health status. So we basically introduce an interaction term on this strict regulation for also being in fair or poor health. And again, we would suspect that the effect would be stronger here. Again, we don't always find the relationship that we expect. It's kind of a little bit all over the place depending on the age and the outcome measure that you're looking at. And on the whole, it doesn't tell a very clear story of who's responding to this, to the increased access of health insurance. The final cut that we do is basically looking at whether you have access through health insurance through your spouse's employer. And here, again, we would have predicted that the effect was negative and significant for the people who have access to health insurance from their spouse. But again, we find very mixed evidence, and the interaction is positive and significant, and sometimes it's negative and significant. So unfortunately, it doesn't really give us a very clear story to tell you, but overall, we feel that so far we haven't found strong evidence that these rating regulations will affect retirement behavior. But we have a lot of ideas for how to push this forward, and again, we're looking forward to your comments, but we'd like to see whether people who currently have health insurance are more responsive to these rating regulations, basically cutting the sample down to people who we think should be most responsive and seeing if we can find anything there. Also, instead of just looking at retirement behavior, it'd be interesting to look at intensive measure responses. So looking at whether this changes the incentives for people to work full-time or not, or changes the number of hours that they work per week. We also, my co-author actually just recently obtained special sworn status to use the MEPs along with state identifiers to get a sense of the average individual health insurance premiums that are available by state. And the idea here is maybe we can use the regulatory environment to instrument for the prices and then understand how responsive people are to prices in the individual market. And ideally, that would also not only tell us about the rating regulations, but also give us more evidence about how people are going to respond to the subsidies as well. We also have yet to incorporate any state level changes in Medicaid eligibility, which there haven't been that many of over this time period, but it's worth doing. So at least at this point, what I would say our implications are for the Affordable Care Act and retirement. It appears to be that we have little evidence that the regulatory environment influences retirement timing, but I think consistent with the CBO report, at least the information that I have in the CBO report, the effects of the Affordable Care Act on retirement behavior may depend more on changes in health insurance offering in the employer market or the impact of these subsidies rather than the rating regulations per se. So I'll end there.
I just wanted to go through the kinds of decisions that someone who's 62 years old, might go through if they're deciding whether to retire when they're thinking about health insurance. And so there's sort of two paths. One is you stay employed, and that's a very simple decision. If you happen to be at an employer that provides health insurance, then great. You get health insurance that way. If you're an employer that doesn't provide health insurance, or you're in part-time work or whatever, and your spouse doesn't have health insurance, then you can decide to go on the individual market. This is before the ACA, and buy health insurance there, or just go without. Right? That's very, very, very simple. And then the second possibility is that you retire. And Gopi went through this very nicely. So you retire. If you have retiree health care, you get that. That's wonderful until you turn 65. You can do COBRA, which lasts for 18 months, as expensive. You can go again to the individual market if neither of those two work for you, and then finally you can go without. Right? Those were the choices. I wanted to highlight in red the things that are sort of group rated or community rated in states that didn't have these community rating laws that Gopi was talking about. The reason this is important is because this gives you a sense of whether there's a subsidy, right? So if you're in one of those reds, you get, in a sense, you get an implicit subsidy because so for instance, I'm getting old and decrepit. I got white hair. Luckily, Stanford hires all these young assistant professors who are in the same group plan as me. They're essentially subsidizing my health care because they don't make any distinction. We hired Mark, and he's subsidizing my health care, which is fantastic. And so you see there's an implicit subsidy involved. But the key question here is, what group are you linked to? So which group are you? So if your employer provides you coverage, the key thing is how healthy and how old is the workforce that your employer happens to have. That's the group you're linked to. Similarly with COBRA, that's the same. It's essentially the same group. On the other hand, if you go on the individual market in these states that didn't have the regulation in the old days, it was basically it was actuarially fair, right? So it was based on your age. Age and sex and whatever they wanted to measure on. So that basically. So in other words, in these red areas, you got some subsidy. Okay, in the states in the pre-ACA reform states, those are the states that Gopi relies on to identify our estimates. What happens is the individual market also is community rated. And now, again, the group isn't quite the same. The community rating is not the same thing as community in one context, and not the same thing as community rating in another context. So now it's all of the people who also go for that same insurance plan, and you're community rated with those people. So it depends on are those guys sicker or healthier. It's kind of complicated. So I just wanted, and it's hard to know in advance, sort of how large the subsidy is going to be. And so let me just make a couple of quick observations about this. One is that in principle, anyways, community rating reform should have made the individual market a lot more attractive to older people, like near elderly people. And the reason is that you get subsidies, just like I'm getting subsidies because Mark is so healthy. So just similarly, if you go on a market and you go in this individual market and you're sick or near elderly, you get and the plan you sign on to happens to have lots of young people in it, young and healthy people on it, you're going to get a subsidy. But the second thing I want to make an observation on, this I think partly explains what Gopi's results, is that you'll notice that the individual market reform affects both paths, both the retiree path and the employment path. Right? If you stay, it's a subsidy to both paths. So in principle, you might expect, ex ante, I would have expected until I read Gopi's paper that this path, this retiree path, this would have been more salient. But of course, that's not what they're finding. But and the key thing is to note is that on both paths, essentially you get the same subsidy if you choose to go along it. And of course, it's complicated, and they're doing a reduced form approach. It's a little hard to disentangle, but but I think that this may be one of the reasons why they're finding sort of small results. The second thing is So something I want to focus on is does the conclusion that Gopi finds will it hold when we're looking at the effects of the ACA's incentives on retirement? Because I think that's really that's the reason to be worried to think about this issue at all, really. So let me this is the same thing. All I've done is I've changed it up a little bit to reflect the changes with the ACA. And so what the ACA done is, instead of having this individual market, we're going to have a subsidized exchange insurance. So there's really the main difference there. It's as if you have a post-reform world. Every single state that had that reform now is in the ACA you have to have community rating. So you get that same subsidy, from Mark to me that we had before. But then there's another subsidy, which is that if you're low income, you also get money to buy insurance straight up. Right? So if you're between 133% of the poverty line and 400% of the poverty line, you get an additional subsidy on top of it. Right? And now you, of course, notice that it's on both sides, both retiree and non-retiree. Okay, so now there's one other wrinkle. I think this is really important, and it's sort of a hobby horse of mine. And since it is, you guys get to be exposed to it. The ACA is going to have a huge effect on the incentives for employers to provide insurance in the first place. And so what I've done is in a completely non-scientific basis is shrink the arrows where I think the arrows are going to shrink, not proportional to actually any evidence, but just my gestalt. Just so you get some sense. So for instance, employer-provided coverage, group coverage is especially if you're in relatively low income or part-time, is going to shrink. I'm sure you guys all saw this thing, right? The Walmart thing. I mean, I think that's the beginning. I don't want to focus too much on this, but I think that's real important. The thing I shrunk the most is retiree health insurance, retiree health care. Because I think the ACA basically gives very strong incentives for employers to just say to retirees, go, head out to the exchange. And I'll just give you some sense of how important that is. In private sector work, it's about 17%, maybe 16 or 17% of all workers have some form of retiree health insurance. That's a pretty significant chunk. The incentives the reason why the incentives are there is because the employers pay no penalty if they send their retirees to the exchange. And since retirees tend to be lower income, they're more likely to qualify for subsidies. It might actually be a win-win situation. The federal government pays the retirees to have health insurance through the exchange, and the employer saves the money on health insurance. So I've done some calculations on how much state and local governments would save if they were to take all of their retirees and send them to the exchange. So state and local governments as employers, how much would they save? And it turns out here's the number of state and local government employees across the country, sort of color coded. Here's the number of state and local retirees under 65. You can see California, for instance, has a significant number of them, perhaps not surprisingly. And here are the fraction of them that are between 138 and 400% of the workforce of the federal poverty line. That's important because that's how many qualify for subsidies for the ACA. And if you run through the numbers, I'm not going to go through any of the details of this, but so for instance, California could save $1.8 billion a year if it were to shift all of its retired workers onto the exchanges, and make the workers whole, so they wouldn't have to pay any extra premiums. This is after all the tax effects, after making them whole, so they don't have to pay any extra premiums. California would still save $1.8 billion a year. Is coming off the subsidy. That's the main thing. And now there's some little tax changes, right? Exactly. Now, of course, it makes different insurance and all that, so there's complications. But just to give some sense, there's going to be some very strong incentives if states are facing budget crises to say, look, here's something we can save, and it's ACA insurance, so in principle it's good insurance, right? Okay, so a couple of observations. So one is the ACA is going to push toward delinking employment and insurance coverage. What does this mean for the retirement incentives? I think it means that just focusing on this community rating reform alone, I mean, Gopi said this, underestimates the effect of the incentives to retire. And in particular, I think the community rating, of course, is an implicit subsidy of the near insured, but the ACA also has an explicit subsidy that depends on income. If you've delinked work from employment and you're close to retirement, if you've delinked work from insurance, actually, I kind of would like that too, if I kind of think about it. If you delink it from employment from work from insurance, and you're near retirement, I mean, that's, I think the intuition that we probably all have, that this thing over here will dominate this thing, this side, is, especially when there's large subsidies involved, is likely to be true. And I think it would be interesting to see, and Gopi mentioned the CBO report, to disentangle how large these various mechanisms are. And I think we still have yet to know what the effects are ultimately going to be. Okay, thank you.
Yep. Yeah, there's a microphone. I think we're going to be recorded. While I was getting there, I should say that the first paper had 2 postdocs, and the second paper had 2 of my former students, so I'm doing pretty good.
Yeah, I had sort of a similar point to the one that was just made. I was a discussant of this Garthwaite et al. Paper last year that looked at the TennCare Tennessee, where they had put a lot of people on Medicaid, and then got into a fiscal crisis and took all of the single males out, and there's Garthwaite et al. Wrote a really nice paper, sort of as a kind of natural experiment, where they thought that this would be like running TennCare was like the TennCare reduction was like the ACA in reverse, where ACA would expand this, and they argued that, and they found results that had fairly substantial labor supply effects amongst these single men who were taken off of Medicare or off of Medicaid. And my point was basically like Jay's. It's saying that these really low-income people, they're not getting any significant tax saving. I mean, it's worthwhile giving me a raise in terms of health insurance coverage rather than cash because I have a fairly high marginal tax rate. On the other hand, people at low income levels have very little, and so at those low income levels, they're basically taking a cut in their take home pay in order to have a health benefit. If there's going to be a strong incentive, I think, for the firms that hire these people to shed the private health insurance for the reasons that Jay went on. Once that's happened, then the compensating wage differential that would be going on would not happen, and you'll tend to get a rise in the demand for these low-income workers. And I did kind of a back-of-the-envelope calculation on that, and it turned out that the 2 effects very nearly cancel, so that you would get no effect. So I think a lot of it depends on sort of which part of the labor force that one's thinking about. Sort of what are the incentives to keep firm supplied care? Who is going to shed care, and then what are the further kind of more general equilibrium effects having to do after that?
I'm not sure how up to date I am on COBRA coverage, but at least as the law was passed, employers don't have to give any subsidy to people who get that 18 months after their employment ends. In fact, they're permitted to charge 3% more than their total premium cost, combined premium cost to their employees and to themselves of the insurance. So that's not a route to get a subsidy. It's a route to get essentially community-rated insurance plan, which is still a very valuable right when you might have to pay much higher premiums outside of group coverage. The claim that employer coverage is going to shrink is probably right, but one thing to bear in mind is that the law does contain penalties, financial penalties on employers, larger and medium-sized employers that don't offer any health insurance. And the way to think about those is is it worthwhile to the employer to pay those penalties and not provide qualified insurance, or are they better off offering the insurance plan? And the logic of most economists here is, well, if they pay the penalties, then there's nothing in it for either themselves or their employees. And so if health insurance even has some value to their workers, the penalties make it attractive for large and medium-sized employers to offer health insurance to all their plans. And I think CBO accepts that, and I think most people looking at it. So that's one route where employers are not going to be walking away for health insurance plan. Whether they walk away in providing health insurance to their part-time workers is an open question. Remember, some of the people who will lose health insurance if they do that are people who will not qualify for subsidies. And having a health insurance plan seems to be a very attractive feature of employment in the United States. So it's a little unclear, and I certainly wouldn't trust an employer's description of why that employer took an unpopular action, such as removing a lot of people from health insurance, at face value. Employers have been taking away health insurance from some of their employees for a long, long time before there was an Affordable Care Act. So the notion that Walmart describes its rationale in terms of the Affordable Care Act is very convenient for them. It seems to deflect the blame, but I wouldn't take it terribly seriously. I would instead analyze what's going on. It might be that it's the Affordable Care Act, but it might be completely independent of the Affordable Care Act because long before there was an Affordable Care Act, there were employers taking away health insurance plans. But having said all of that, I certainly said, even at the time the Affordable Care Act was being considered, that it is quite reasonable to think that there are a lot of people between 55 and 64 who will have one less reason, especially if they have some sickness or if they feel some disability, to be employed. So I don't know what the right number is. I don't know whether CBO's latest number is the correct one, and I agree that TennCare finding certainly supports that view. The empirical magnitude of this effect is anyone's guess. I don't think, as long as we have excess levels of unemployment in the United States, this is affecting aggregate labor supply in the United States very much, because to the extent that some people withdraw from the workforce because they don't need health insurance anymore, there are plenty of young people, there are plenty of middle-aged people who are jobless who will take those jobs. So I don't think it's affecting aggregate labor supply at the moment, but at full employment, I think it's a very real possibility.
Short-term effects are expected to be lower because of the still higher than normal unemployment rates.
Two questions. You showed the slide that gave the number of states with strict regulations. I had two questions to that. First of all, there's not, as you pointed out, there's not much change there, but that's kind of the net change. Are there more gross changes underlying that? Or are you really identifying this from a state here and
Those
there?
are actually all the changes.
And what states are they? Are they big
It was
states?
Kentucky. I have it written down. It was, let's see.
Well, if it's
Kentucky,
a very
Maine,
small number of states,
Massachusetts,
you
and
might
New Hampshire.
think about
Yeah.
is there a narrow set of states that are better comparison states,
Yeah.
conceivably? The other is you said you had to have, the two kinds of regulation to be strict. Is everyone else in the other bin, or are the states with neither?
There are states without either.
So that's the simple comparison, okay. And the other question was, I guess any of these pictures work. Oh, no, sorry, it's the wrong one now. Can you see more people buying private insurance when these regulations change? I mean, it seems if that doesn't happen, obviously, and the retirement, dependence on that might be pretty weak. That you need a pretty big effect on the kind of the quote-unquote first stage to get anything here.
Right. We haven't looked at that exactly, but there has been other work that looks at the size of the non-group market and how it responds to these rating regulations, and it seems that there is a response. So more people are purchasing individual insurance. We didn't look at that in our data.
Just a comment. There are other considerations just than the premium and the availability of insurance. particularly on purchasing individual insurance versus staying with your employer's plan. And for those people who've had a significant medical issue, they realize that if there's any kind of dispute with the insurance company, they're a lot better off in an employer-sponsored plan where the employer has negotiating power versus if you bought just an individual policy, it's you against the insurance company. And so I can attest personally, I am in a retiree medical plan from a former employer, very good employer, negotiated good insurance. My wife and I both had significant medical events. We are very, very grateful. We are in a good plan, and we're not us against the insurance company. And I know, because again, I give retirement planning workshops, I know that's a consideration that people want to stay, particularly if they have a large employer with a good plan. They just don't trust the insurance companies if they're against them on an individual policy. Hard to quantify the impacts of that, but I think one of the impacts is that people who are aware of this, most people aren't aware of this issue, it's the people who have had a medical issue, maybe the more high-cost people that are aware of this, more likely to stay with the employer-sponsored plan. So I just wanted to share that's another factor in the decision-making here.
Okay. Any other questions, comments?
Just a wisecrack, prompted by Jay's. This stuff is saying separating work from employment, and we all know colleagues who have done that very successfully. And I heard one, I didn't actually hear this, but I heard of a professor saying, the university may determine my annual wage, but I determine my hourly wage.
The CBO estimate, the 1.5% to 2% of the labor force, I mean, that translates, I suppose, to 1% of GDP, conservatively, $180 billion a year, lost labor income. I suppose that you could value the leisure or something, but I mean, this is, so it strikes me as a pretty big loss for a system that is, basically transferring money from, one group to the other. But wow, 180 billion. Yeah. We could have tried it, but it might have been an incomplete pass with a bad throw.
So I'm sitting next to Kathleen, so I think I should ask a question about whether retirement is retirement and how we're kind of taking account of the fact that it's now a 17-stage process. And, I mean, I don't know what all the partials are. I don't even know how to classify them. I don't know how to classify kind of doing something you really enjoyed and selling it as a creative product. I mean, is this just going from, as it were, I mean, there might be a lot of self-employment that happens. I don't know what happens next.
Yes, our retirement outcome is just relying on self-reports, and so you categorize yourself as either completely retired, partially retired, or not retired. Right now, the measure that we're using is one if you're partially or completely retired, but we could change that to look at just complete retirements and see if there's any difference in. I think what you're asking is a
Yeah, I'm just trying to think about.
what you're asking is kind of a deeper question on what does that even mean? Like,
Yeah,
really-
I mean, for example, when I hear the word retirement, am I supposed to translate that into something permanent? I mean, was that what I said, or did I mean I'm currently fully retired, and next time you ask me, I might be fully unretired? I don't know how people translate that word.
That's partly why we use the three different measures, because the self-report, I think, has those issues, whereas the exiting the labor force doesn't have exactly those same issues, because it's literally, are you working for pay or not? So that's more of a measure of your actual behavior rather than how you see yourself.
But you could be earning income. You could say, I'm not working for pay. I'm just trying to understand, I mean, even the semantics is difficult.
Yeah. No, I agree. There's not a great, one measure to use when you're looking at this type of outcome.
Okay. Oh, we have,
So one thing that's very different now in the environment now is the availability of the subsidies. And so I'm wondering if you could follow up this study looking at more recent data, trying to exploit maybe variation across states and the magnitude of the subsidy. So what I have in mind, if you look at the 60-year-old couple, let's say, the ACA subsidy is like 80 to 85 to 90% of the premium if you're at around 200% of the poverty line. Whereas, for someone younger, for 30-year-old couple, the subsidy is pretty small as a share of the cost, but health insurance premiums vary pretty enormously across states. So for example, in Iowa, the premiums are a lot lower than in, let's say, New York or Massachusetts or somewhere else. So you might be able to, this wouldn't be for this study, but for a follow-up study to try to sort of look at this in an environment with the subsidy, because the subsidy really changes it. I mean, you have a 30-year-old couple and a 60-year-old couple, they essentially pay the same amount. There's this 3-to-1 age rating, but if you're getting the subsidy, those two couples pay the exact same amount for the same plan, and that difference matters more, I think, in high premium states. So it's just be a way, like with the monthly CPS even, to see if anything is happening differentially in high premium and thus high subsidy places of late. So.
Yeah, totally agree. Maybe the SIEPR Working Longer Conference of 2018 or something. So.
Okay, on that note.